ganglion of impar block. So as we all know, it is a single terminal ganglion of the sympathetic chain, and it's located in front of the sacrococcygeal junction. It is also called as Walker's ganglion, and it has distal efferents from the perineum, distal rectum, anus, urethra, vulva, and distal one-third of the vagina. It was Plancard et al. Who first described the block in 1990. And it is indicated in chronic coccydynia, pain mediated by the sympathetic nerve from the lower parts of the gastrointestinal and the genitourinary tract. As we all know that this is the last part of the sympathetic chain, so mainly the lower one-third, malignancies of the lower one-third of the genitourinary or the gastrointestinal tract can be treated with ganglion of impar block. Also, sometimes post-herpetic neuralgia of the perineal area can be treated with ganglion of impar block. It can be done in various positions like prone, lateral, and lithotomy, but the commonest one is the prone position. Various techniques have been described for doing the ganglion of impar block. The commonest is through the sacrococcygeal junction. First needle which you see is through the sacrococcygeal junction. The second foray and all described through the first intercoccygeal junction or the second intercoccygeal junction, and the last Plancard et al. Described the block through the intercoccygeal ligament with the help of a bent needle. But the commonest one practiced nowadays is through the sacrococcygeal junction. So I'll be describing on in ganglion of impar in the prone position through the sacrococcygeal junction. So as we all know, the patient is placed in the prone position with pillow under the abdomen to allow flexion of the lumbosacral spine, and the lower extremities are internally rotated. Once we have the C-arm is in the lateral position and a skin wheel is raised with 1% lidocaine using a 25 gauge needle over the sacrococcygeal junction after identification of the disc in lateral position. Important point in this is we have to obtain a true lateral image, which is by superimposing the greater sciatic notches. I will be describing that in my video. Next, once we have given the local anesthesia, a 22 gauge needle. Here I am describing the needle and needle technique, wherein a 22 gauge needle, 1.5 inches that serves as a guide, is introduced under fluoroscopy guidance through the sacrococcygeal disc. And through that, you put in a 25 gauge 2-inch needle is then introduced through that 22 gauge needle. Okay. So you can see that picture on the left. So this is a small video. So as I said, superimposing the greater sciatic notches, you can see the greater sciatic notch, two are superimposed on each other, and then you detect the sacrococcygeal junction, and my needle is going through the sacrococcygeal junction. Once my needle tip is in front of the anterior coccygeal border, I'll put in a radiopaque dye and see the spread of the dye. Usually the spread of the dye is what we describe as a comma shaped in the retroperitoneal space. So once you get a good dye filling, and then you will inject your local anesthetic and steroid. Okay, so this is how the representation of the dye spread in the retroperitoneal space. Okay. Once you have confirmed or it's a diagnostic block has been done and the patient is come with cancer pain, we can also do neurolysis procedures or radiofrequency ablation. If radiofrequency lesioning is contemplated, a pair of 20 gauge RF needles with a 10 mm active tip placed parallel to the straddling the midline just anterior to the coccyx, about 5 to 6 millimeters apart, and a bipolar strip lesion can be created at a temperature of 70 degrees for 90 seconds, 70 to 80 degrees for 90 seconds. Okay? So, or otherwise, we use neurologic blocks using alcohol or phenol, as we have described in the previous blocks. This block can also be done ultrasound guided. Ultrasound guided ganglion of impar block is usually mostly preferred out of plane because in plane there's hardly any space to put in your needle. And also, because of the proximity of the rectum, you have to be very careful for chances of infection. So you do out of plane, we can use high frequency linear probe, but if the patient is obese, we can also use a curvilinear probe. So the sacral hiatus is palpated, and a linear high frequency probe is placed above it. Once you identify the sacral hiatus, you turn the probe to 90 degrees. Okay? So this is a technique.
Yours is only CT guided and not ultrasound.
Okay, fine. Alright, sure. So I'll skip this.
Show it under
CT, I don't practice CT, so it's mainly fluoroscopy what it has practice here. Sure. So complications of this procedure can be mainly rectal injury, injection of the neurolytics in the nerve roots and rectum, and cauda equina, which is very rare. But tips for this procedure is mainly sometimes you can encounter calcification of the sacrococcygeal junction. So difficulty in placing the needle. You can go through the intercoccygeal joint if that is the problem, or needle-in-needle technique can be of use in those in the calcification. Thank you.